A 72-year-old man presents to clinic with phantom and residual limb pain after a transtibial amputation and osseointegrated implant placement with concurrent RPNI or regenerative peripheral nerve interface placement at an outside hospital. The patient reports his pain as an 8 out of 10 on the self-reported pain scale. The pain is noted to be largely localized to the distribution of the saphenous nerve. The problem list includes phantom and residual limb pain in the distribution of the saphenous nerve refractory to attempted RPNI placement. How would you face the case? Option A, combined targeted muscle reinnervation, vascularized RPNI or regenerative peripheral nerve interface placement, and peripheral nerve stimulation. Or option B, onward referral to the multidisciplinary pain clinic for review and further non-surgical management. The votes are in and you chose A.
Hello everyone, my name is Jose Telich. I'm a plastic and peripheral nerve surgeon located in Hospital Ángeles Pedregal in Mexico City. I would like to thank PRS Global Open and Kevin for their kind invitation to be a part of the Face the Case video series today. First of all, I would like to congratulate the authors of this magnificent paper, in which they present a novel approach for the management of chronic residual limb pain, in which they combine targeted muscle reinnervation, regenerative peripheral nerve interfacing, and peripheral nerve stimulation for the successful management of chronic limb pain. All of these truly state-of-the-art techniques. The case describes an elderly man who underwent lower extremity amputation with RPNI and osseointegrated implant placement, but who unfortunately developed chronic pain after said surgery. This may have been due to a small cuff of muscle around the nerve end after RPNI, or a superficial location of the nerve end resulting in painful neuroma. The authors employed TMR, vascularized RPNI, and peripheral nerve stimulation to address the patient's concerns. Targeted muscle reinnervation is a technique that transfers a mixed or sensory nerve to a motor donor that goes to an expandable muscle, giving the transected nerve a target to prevent disorganized axonal growth. However, when there is significant size mismatch between both nerves, there might be some axonal escape, and this might result in a neuroma. RPNI involves the implantation of the nerve end into a denervated muscle graft. The muscle graft provides empty motor end plates that serve as targets for the sprouting axons, and this decreases disorganized axonal sprouting and neuroma formation, but lacks a nerve that works as an axonal conduit. Another limitation of RPNI is that the muscle cuff is a graft and therefore it's devascularized, so the size of the graft that can be employed is limited. This was addressed by the authors who presented the use of vascularized RPNI, which addressed this concern and allowed them to use a larger muscle cuff around the nerve. In addition to TMR and RPNI, the authors placed an inflatable nerve stimulator that worked both as an adjunct for pain management and potentially to stimulate axonal growth across neuropathy. The combination of these three techniques resulted in a pain reduction of 50% and improved quality of life in our patient. Traditionally, pain caused by neuromas has been addressed by surgeons by resection of the neuroma and burial of the nerve end, but overall results tend to be suboptimal due to a high recurrence rate. In addition to this, patients with chronic pain may also have decreased quality of life, may avoid the use of their prosthetic devices, and may require higher doses of pain medication, also rendering them at risk for opioid abuse. Therefore, employment of non-pharmacological strategies for pain management is very important for this patient population. Increased awareness of these techniques to address neuroma management is needed both among plastic surgeons and our referring colleagues to improve our patients' results. Further investigation and reporting of how to best employ these techniques, such as timing, combination of the techniques, is critical to elucidate how these strategies might yield better results for our patients. You can read these and more interesting case reports every month on prsglobalopen.com, and we will see you next time on the next PRS Global Open Face the Case. ¿Y tú cómo resolverías el caso?